That was quite overwhelming, and he has actually eaten up my 15 minutes. Whatever I was going to say, he has already said. So deduct that 15 minutes from my talk. So at the outset, I would like to thank the management at Ruby Hospital, specifically the owners, Mr. Kareem and Mr. Ali, and Mr. Jameel, Mr. Ashton, and Vinod, for inviting me here. And of course, Pranit and Shridev, they've been in touch with me on a regular basis. So thank you very much. And thank you all doctors, Dr. Arafat, Dr. Blessing, my colleagues, and all of you for spending out your time and coming here today evening. So, just first line. So just I came to Uganda only yesterday, but I've been talking to Vinod and Mr. Jameel for quite some time because I just wanted to. It was a very cordial thing that happened. I wanted to know what's happening, and with Vinod being here in Ruby for last almost since January. Significant amount of changes have happened. Protocols, with the help of the management has been very kind to him and the other people. Protocols have been set, ICU protocols, OT protocols, the main OPD thing, and many other things which are essential. So, can I see my first slide? Okay. So this is the back. So this is my operating room. That is me operating in my OT in Mahim, Hinduja. So I'm in neurosurgery since 2006, and so it's almost 19 years now. And I'm associated with Hinduja since last 17, 18 years. And of course, my dear friend Blessing is here, and me and Blessing were together way back in 2014 in India when he and his friend were here. So so that's my operating room in Mahim now. And the image on the right side is something I'm fixing a frame on the patient's head. That's called gamma knife radiosurgery. I'm sorry, in the rush of making the presentation, I have not put a picture of a gamma knife machine. It is something very similar to an MRI machine. So it's a radiation machine. It was the first one to be installed in Hinduja in India in 1995. And since then, in India, we have around 5 machines in India, approximately, if I may count. And we have the latest one, that is me fixing the frame on the patient's head. Then the patient goes, does an MRI, then we do the planning, and then we give the radiation, and then once the radiation is done, we remove the frame. So that's my assistant holding the frame, me fixing the frame, and yeah. So these two images, I had just gone to the OT yesterday just to see how things are. And the image on the left side is the Karl Storz endoscope trolley, which the Ruby Hospital has procured recently, and they have got lots of instruments with it. I was seeing all of them yesterday. Various ENT instruments, various scopes, and which can multiply used in the orthopedic surgery, neurosurgery, ENT, etc. And on the right side, if you see, there is a microscope which my partner and my colleague, Dr. Arafat, all of you have said that it's the one of the latest in the industry by Leica, and it's a good microscope. See, these small things, they do matter a lot when you want the patient to go home walking. It just doesn't happen just like that. It's just not the surgery. It's the instruments that we get to use also makes a huge difference in giving the patient a good output. So see now, all of your doctors. So I don't want to teach you anything because you guys are already. If there's a resident, you guys are already into your education program. The consultants already know their stuff. So I don't want to teach you anything. But these are just general images of scans of patients, which I just want to introduce you. The residents can know. I heard there are a lot of general surgery residents here. If you guys are keen to take up neurosurgery going forward, you should know what you are getting into. So just an introductory. So the images on the first left, I don't know, laser pointer. Okay, the images on the left side first, those are the picture of a glioma. Now, these kind of gliomas, usually initial days, early days, we do operate, and based on the biopsy, based on the diagnosis, the patients are further referred, either based on the grade of the tumor, either patient will be referred for a radiation or chemotherapy. With the advent of the microscope, all these surgeries, all the pictures that you see here, the life becomes very easy because optics is everything in neurosurgery. You can't see things with your naked eye. And to be honest with you all, in neurosurgery, if we get a 2 millimeter gap or a 1 millimeter gap between two structures which are very important, it does make a huge difference in the post-operative output. That is a 1 millimeter gap between two nerves, or 1 millimeter gap between the vascular structure and a nerve or a brain matter is a huge margin. And the magnification that this new microscope will provide, it helps us adjust, helps us give you the patient a good output. So these are just images. When we go to the right side, it's a high-grade tumor. On the extreme right, it's a meningioma. The left side one, downstairs, if you see, it's a picture of a colloid cyst. It is something which can be done with the help of an endoscope, which Ruby Hospital has recently procured. Previously, if there was no endoscope, we'll have to go with a bigger exposure, go via a microscope. But with an endoscope, the exposure comes down, and the hospital stay for the patient can be less from. Back home, I usually discharge my patients on the third day or something. They go home walking usually, by God's grace, touch wood. But with the help of endoscope, this stay can go down further. Then the middle image, the middle image is something. It's a very big tumor in the posterior fossa. So MRI is an MRI. It just shows you that this is a tumor, but how to take it out? We need. I mean, let me be very casual with you. We need good jazz. We need good stuff. We need good instruments which help us make my life easy. Otherwise we have to struggle. If a surgeon struggles in exposing the tumor, what will he do while operating the tumor? Because that's where it matters. At the end of the surgery, when we are operating a tumor like this, it takes 7-8 hours, isn't it, blessing? It takes a long time. We get tired. So all these new things that are there, the microscope, the endoscope in cases which is indicated, makes life easy. When the life is easy, output improves. And that's what matters a lot. The last one, this is the pituitary tumor. The pituitary gland, the normal person will have a small gland the size of a pea. In this patient, again, pituitary tumors can be helped and operated with the help of endoscope, which these guys have now. Well, these are certain trauma images I was presuming, especially for the residents. Are you guys exposed to neurosurgical cases in your residency in general surgery? Do you operate on neurosurgical trauma cases? Yes, very good. So the extreme left, the subdural hematoma, extradural hematoma, very common trauma cases. This is intracerebral hemorrhage, can be because of trauma or most commonly hypertension, blood pressure. The images below are frontal depressed fracture, secondary to impact injury. These are common surgeries. Usually, being honest with you, a good microscope helps, but trauma surgery is more time bound. It's a time bound essence. So next one, please. Yeah, this is something which can be, this is good. So this is the left side, these are the cervical spine images with disc prolapse, cervical canal stenosis. And the lower down, if you see, is a lumbar disc prolapse. So Dr. Arafat must be doing all this. And by the way, let me thank you. You told me that we have neurophysiology, which helps us a lot when we operate spinal tumors, intramedullary or intermedullary extramedullary, because with neuromonitoring, again, we know where to stop. See, it's very important in neurosurgery to know where to stop. Otherwise, you'll keep going, and then, at the end, the patient gets up with a deficit, right? So neurophysiology is one more tool which he mentioned, and very rightly, which helps us in our output significantly. Next one, please. So these are under spinal tumor. The left side is a spinal meningioma, CV junction tumor. The right side is a Chiari malformation, which is a congenital problem. The left lower one is a basilar invagination, spinal surgeries. The right side, this is near the sacrum. This is congenital deformity called detethering of cord. Again, these kind of surgeries, we need a very good microscope and neurophysiological monitoring. Without which, again, it is a difference between a patient getting up, coming out of anesthesia with a foot drop. The neurophysiology monitoring does help in this. Next one, please. So we'll keep jumping now. This presentation was initially made because I was thinking some other crowd will be there. We'll go on to the next one. Next. So this is stroke basically. Go back one side. This is ischemic stroke, this is hemorrhagic stroke. These are all emergencies which we see in neurosurgery. And the causes of stroke, I'm sure every one of you know it. So I'll just go to the headache.